Who's supposed to be questioning Dr. Diba? I think it's Tunkara. Tunkara is not online. So I think we can move to Dr. Jalo. Do you have any questions for Dr. Jabi? I think Dr. Diba, thank you very much for those interesting responses. So we just want to start having questions so that we can wrap up. I know it's been long, but we apologize for the technical issues. It's still ongoing, so we are just doing our best. But the staff of the research center are doing their best. So I'm not sure whether Dr. Jallo might have anything to add to what Dr. Jabi said, or any burning question or whatever. You might want her to further explain something for the benefit of all.
Yes. What's going in mind is anomaly scar during the antenatal follow-up. Is there any strategy for anomaly scan, considering that we are receiving most of our babies very late? Now the trend in the world is to diagnose congenital anomalies in babies when they are intrauterine, when they are in the womb. And then this really increases a better outcome. So I don't know if there is any strategy for anomaly scan in terms of training ultrasonographers, provision of ultrasound machines, having capacities, and so on and so forth. In a lot of countries, this is something that is ongoing, and they are making a lot of improvement. Thank you.
Okay. Thank you very much, Dr. Jallo. So the issue of anomaly scan, as you know, we have very few radiologists in this country, and then they are almost all of them are in the public sector. They are almost all of them are in Bangalore. The other facilities are only having sonographers that can do the basic scanning to diagnose pregnancy and then just to observe the gross abnormalities. Of course, it's not every woman that we send for anomaly scanning. There must be a point that this woman need an anomaly scanning for us to send you for it. Usually, in our facility, what we do, if there is a risk factor that we think that this woman might have abnormalities, we usually send you for analysis scan. That is, if the mother is elderly, if there is a disease condition that is underlying it, either the patient is diabetic or there is polyhydramnios, oligohydramnios, or any point that the woman the baby might be affected, or the woman is taking certain drugs like those that are epileptic, that we feel that this woman need to have an anomaly scan. We send you very early. That is between 18 weeks to 22 weeks. That way, if there is an anomaly that is not compatible with life, we can actually cancel the patient for termination, or we send you to a specialist in that area. That we refer the patient altogether to Edward Francis, where the expertise are there. But then still, it's difficult and it is very challenging. And sometimes, even if the anomaly scan came back that this fetus is not, there will not be compatibility between when the baby delivered, the baby will not survive. Most, our religion, and then when it comes to terminating pregnancy, it becomes very difficult. Some people still want to carry that pregnancy, or they will let either the child die intrauterine, or they will say when the child comes out, then they will decide. So the counseling has to be continuous. And then in the public sector, the anomaly scan might not be expensive, but in the private sector, it's really expensive. So when we want to send these women for anomaly scanning, because we cannot send all of them to Edward Francis Small, they will not be able to do it because they don't have much radiologists on the ground. But then when you send it to private sector, it's quite expensive. So it becomes very difficult. You might send them for the anomaly scanning, and then they might take weeks actually before they even come back to you with the results, which might be very late by then. Thank you. I hope I answered your question.
Are you satisfied, Dr. Jallo?
Yes. She did only that.
Hello?
That I would quickly want to add that every pregnancy, every woman, we should endeavor. I don't want to use must have anomaly scan. because you may detect something unexpected. And then every woman within the breadth, length and breadth of the country must have. For example, we should not have babies whose intestines are not connected, deliver and been fed, they have complications, they come to us, our outcome is not good. Every woman deserves to go home with your baby. So the to have a best outcome is to diagnose them early, send them early, and we intervene early. So I think this should be a government strategy to endeavor to train lots of ultrasonographers and then to provide the machine. For example, almost every center should have an ultrasound machine. There should be somebody trained to be able to do this scan so that we have a robust, transparent system. With this, we'll have a very good outcome as a poor and a developing country. Thank you.
Thank you very much. Thank you very much. And Dr. Jaffe, do you have anything for now your turn? If you have anything to add to what he's been very thorough with us talking about these babies? Do you have anything to add?
No, I don't have it.
Okay. And then Dr. Diba, do you have anything for Dr. Bojang?
No, because what I was just wanting to ask was the prevalence, and I think during his deliberation he talked about the yeah, I think he talked about the work of Nana, the works that Nana agency did in 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 kind of the talking about the distribution of obesity in different age groups. So that was good. I have no other question for him.
Hello. Hello. Hello.
Yes, I can. I said I have no question for the panelists. Thank you.
Hello. Are you people getting me?
Yes, yes, Dr. Hadi, yeah, we are getting you. Maybe you
Yes,
can
I
go
was
ahead.
trying to log in since at the beginning when I was called to ask question, but I don't know what was happening. You were not hearing me. My question to Doctor is that concerning the health insurance. Uh, what do you think should be in place to ensure that at the primary healthcare level they are adequately reimbursed? Because we're talking about these three tiers, and at this moment they are not paid. It is most of the time, especially if you talk about the village health services, the village health worker, and the traditional birth attendant. It is the villagers through their uh, revolving fund when they are seen and the amount of money that they are paid, that is what is being used to buy their drugs. So how do you think that this insurance scheme can be useful in ensuring that we have adequate resources for those people at the community level? Thank you.
Yes, yes. Thank you so much, Doctor. I think the first thing that needs to be done, and I hope that it's already done, is to do some assessment and mapping. So number one, we need to kind of assess the human resource workforce, and know the anticipated increase in service delivery. The anticipated like kind of increase in the sort of care when the national insurance kicks off. But at the same time, also we really need to understand the burden, the burden. So we need to kind of know the population characteristics in terms of income and also in terms of like distribution. So coming to the community, the people should be able to afford it. I talked about the copay. If there is going to be any, it has to be an amount that will be affordable, that wouldn't create a barrier to accessing it. Because as I said, a huge chunk of the population of the Gambia are not employed. A huge chunk is not employed. From the report that talks about only one third of the working age group are employed. So you want to know how much are you going to task them to pay. And if you task them to pay as part of their service request, whether they will be able to pay that. So you want to know how much, like the different levels. If there is going to be any payment, I don't think it needs to be kind of standardized, like one flat fee as a co-payment for everybody, because people's incomes are different. So again, also, you want to also remunerate the healthcare providers adequately so they could be motivated to provide the services. Then you want to know so how much workload will be added to these people. You want to know how many healthcare professionals are in each facility. All those things will be determining how you are going to structure it. Whether you are going to add more workforce into the system, you are going to increase the remuneration and all that, because otherwise definitely it's going to affect the overall success of the program. Yeah.
Thank you so much, Dr. Diba. I think that's understood. I know we also have some students here. Would you like to take one or two questions, burning questions from any of them?
But then I would like to know what was their history.
Myself, I will not know how to answer it. So briefly, Dr. Jabe, just be brief on this, because I think you've talked about the risk factors, but why would somebody die in theater? We've got two surgeons here.
Okay,
Somebody will tell
thank
you,
you.
yeah, la, la. But anyway, let's hear what you say.
So as I said, maternal mortality is not just a single factor. And then mostly when we take a patient to surgery, it's because the patient is having a complication. Either they could not deliver, or deliver and there is a problem. And then we take them to theater to save their lives. Of course, statistically, I cannot really say that most of the maternal mortalities happen in theater. I don't really know where that is coming from. But then we know that the theater part of our operation is usually to save lives. Either the patient comes with a complication, or the patient came and then developed a complication that we want to save them. That's why you take them to theater, and then in the process, they might die. So I hope that answers. Well, I cannot.
We have another surgeon here. Dr. Jabe, please tell us. Yeah, yeah. The reason why you.
Some parents say like I'm not paying anyhow.
They careless.
And there will be a front for both sides. And it's just but still the parents can have something like this. You just have to cover up for the side. And then they will say that this and
Dr. Jallo, do you want to take that?
Yeah, so
Doc, Dr. Jabi has talked about risk. You know, maternal mortality is a very difficult thing. It's not just one thing. That's the point I want to take to the very intelligent lady. That people don't just die like that. Then it's multifactorial. For example, if a patient bleeds, if a patient is in Bansang, is bleeding, is brought all along, or even Yomi here is taken through Bara, then comes bled, and then it's almost late. When you come to the teaching hospital, we should be able to recover the time lost appropriately. And most often than not, as you are saying, you may lose. That loss now, you don't use that period to define or to classify the cause of the mortality of that patient. You know, one thing in this country that I think we should have a very big discussion on, and then I think this center should be able to bring that up to discuss or to talk on postmortem. You know, it's something that postmortem is in every country. This is something that we should be able to talk on, but it will help us a great deal to know the problem that happens, solve it, and will help us in planning, prevent other mortality. But what I can tell these ladies, surgery in the Gambia before, I don't know. But I had, the outcomes were not good. But for obvious reasons, you don't have very good anesthetists. The surgeons were not many, and then the theaters are not well equipped. But what I can tell you now, especially in the Edward Francis Montague Hospital, we have very good anesthetists who are well trained to be able to take care of patients within the surgical period. We have surgeons who are trained, who have international standards, and who follow standard procedures within the theater setting to make sure that patients leave the theater alive. And then you have also a dedicated nursing team who are trained, perioperative nursing team, who also work very hard to keep this patient, this woman alive with the baby. So now that place is really, there's a lot of improvement. I don't think that should be the worry of any Gambian in this time of an age. Really, we have made a lot of progress. Anesthesia, in our anesthesia, we have professors, we have consultants, we have well-trained nurse anesthetists, we have very good perioperative nurses. This is something that I am very comfortable with. Now, I am able to do 6 hours, 8 hours surgery, and babies go home alive. And I can tell you, if you are able to operate a 1 day old, few hours old baby, then the woman, yes, it should not be a problem. So that place, we should solve that problem. So now I think the discussion should be before that patient comes to theater and after theater, the things that happen. This is where the work should be done. Of course, ongoing work is always on as far as the theater is concerned. Yes, thank you.
Ms. Jete, are you clear on that? Because the problem is, when people are out there, and just I can understand your question because you're a member of the community, all you hear is the negative aspects, but there are a lot of positive things going on. A neighbor of mine is bereaved just 2-3 days ago, and I went there. And when I went there, I felt uncomfortable. You know why? Because everybody is complaining. It's actually to do with maternal mortality. The woman delivered on a Sunday. Following the next Sunday was the Ngente, and she died on Tuesday, just this past Tuesday. And when I went there, everybody was looking at me because people knew in the neighborhood that I'm a doctor. And you can see them looking at me, just talking, and then they were making very loud comments, in all sorts of languages, in Wolof, in Mandinka, that people are just dying in these hospitals. People have to do something. People have to this. So but I wasn't there to be talking to everybody because that is not the time. Our nerves were very raw for me to be telling people, in fact, what happened was, the patient delivered, 3 days later, she died. Yes, it's still maternal mortality, but I don't know. She died on the way from the house on the way. we don't know what happened. But this is what happens when you are a member of the community, especially if you're, health service provider, you hear all sorts of things. So I'm glad that this sort of forums are going to be going on, because then we can clarify things that look, it's not, we are not there to kill people, per se. Some of these things are actually multifactorial, like Dr. Jabi said, and like Dr. Jallo has said. Health has really gone a long way in the Gambia. It's gone far. We'd like to take it to further levels, and we are all part of this. So I'm glad you came here today. So when you go home, you can at least explain things in an intelligent way and said, yes, somebody who has not done any antenatal care, and they're there, somebody who I'm not saying it's probably the person's fault, but then it's also not the doctor's fault or the clinician's fault, so, but then nobody sees that. What people see, is that, oh, she went to the hospital and died. And this person was on the way going, but I was bombarded with comments, not directly at me to say, I'm talking to you, but you know what they were saying, so, and the maternal mortality is sad, I have to add. Nobody wants to see that, but this issue of multifactorial is what I want to emphasize on. Can we take one more question from, okay, we'll have a guy.
I think this is more of a comment than a question. Especially when we said went to a funeral, a lot of comments were made against us. It was very, very uncomfortable. But I think one of the main fueling factors is how we handle some cases. I will take an example of life.
Injury.
Something like that. A few months ago, if I am not mistaken, a foreigner or Indian died in the hospital. The health minister has to decide. It is not directly his fault, but because he feels that he has failed, because somebody has died when he has been decided in his hand. Now, 3 months ago, 69 plus people died as a result of fear of that in the country. I'm not saying somebody should be sad, but I think the comment that was made should not be president. Because once you go in, even if they are scratched, they look at you to know what your actions are going to be like. Most of the cases you go to the hospital, the way I'm not saying doctors, some of these nurses are just like the way they treat you is really unfair. And they are professionals. I think we should have a policy that should really look into those things and definitely something to be taken. Because if actions are not taken, it is going to be very, very more uncomfortable for doctors like you when you go into politics, because that is the eye that people are looking at you. I would have loved to have like people from the ministry so that they know that we are really, really concerned. These are things that we discuss almost every day. Exactly, you are from the ministry. So Dr. So please, when you have meeting at the level of affairs, please make them understand that we are really, really concerned. Now, Gambians are going to more drinking visits young and doctor than actually going to the hospital. Yeah, that is for this. I'm the head of our school, and my counselors here can be the millions. Sometimes students or children in the school. Now, when you ask them to go to the secretary, to swear the medical team and go to the hospital, that nobody can. That is what they tell me. That is because they have lost hope in our health service. Doctors are really trying, considering the population of the country and the population of doctors we have in our country. They are really, really trying. But I think we should make the especially people that are really responsible for us. They need to find out.
Thank you.
Thank you very much. Thank you very much. Dr. Bojang, you being from the health ministry, do you want to take on that?
Not necessarily. What I have to say is it's very important.
Yes. So thank you very much. I think one more. Okay,
we will take from St. Augustine.
St. Augustine's?
Yeah.
Do we have other schools?
Yes.
We've got 2 from Gambia High School.
Yeah.
St. Augustine's?
Yeah.
Yes, let's take the St. Augustine's. Yes, let's take the St. Augustine's. Oh, yeah, St. Joseph's. St. Augustine's and then St. Joseph's. Then we'll have to close this forum because St. Augustine's, you have a question? Please go on.
Okay, first of all, I would like to I'm sorry from St. Augustine. My question, I got it from when the doctor was trying to answer the inspection. She said like some of these parameters are false. When the patient is traveling from a far distance before reaching the hospital, the person will have to eat a lot. So on my own point of view, it's like you guys already know the reason for that death. Because you say that the person might eat a lot. So what are the precautions or what are your plans on dealing with this situation?
Dr. Jabi, briefly.
Okay, thank you very much. So, I think when I was talking, I talked about some of these things, especially when it comes to bleeding. That when these women are coming to the hospitals, mostly they come with very old women that cannot even donate them with a pint of blood, much more when we need other things like drugs and all that. So what we are talking about is, all of these things are usually a cascade of events. It usually starts very early. Some actually the problem starts even before the woman gets pregnant, before conception. The risk factors might be there. Like a woman that has a very close spacing, the body will not even recover from the previous pregnancy and it's pregnant again. So, or a woman that has a background anemia already, when they bleed, even with a small number of bleeding, they will go into shock and then it becomes a problem. So what we are encouraging is once a woman is pregnant and is coming to the hospital, let the woman come with her spouse. The husband should be present. And then if you know that from home this patient is bleeding, don't come alone. Come with other people that have the same information. Because in the hospital, we don't see blood there. And then most people will actually come and say, can I buy it? Because they have this conception that once you donate blood to somebody else, either your manhood is going to reduce, you are going to be important, you are going to be sick. All those misconceptions need to be clear to people. Of course, educating our population is key in managing combating maternal mortality in the first place. So all of these things we need to combat them. So if the patient is bleeding, if you go to our blood banks, most people in this country they don't really go into voluntary blood donation. They only donate when they have a patient or their family member is in trouble. So you might go to the blood bank, you might not even find a blood that is compatible to the patient. So all of these things are delays that can cost a woman her life. So I think those are the things. But once we know that this patient is bleeding, first we try to get blood. We give you fluid, we try to get you blood, and then see how to save that life.
Thank you very much, Dr. Jabi. Somebody from St. Joseph's High School, St. Joseph's. One St. Joseph's, please. We've got two Gambia High School, one St. Augustine. Nothing, yes. Nothing, yes. Yes, please. Introduce yourself, please, first.
Very important because in such situation you lost a patient or somebody, a family member. I think communication is very important because they are emotional state. Sometimes it's not the doctor's fault, and also it might not be their fault as well because there is something that is imminent. It can happen anytime. But communication is very important as it's an emotional state, so they need to be assured. I think we need to work on as health providers the way we communicate to the patient. So my question goes to Dr. Boyam to talk about yeah, we talk about obesity. So, he spoke that if a pregnant woman is obese, there's a high probability that the baby will be obese in the future. So, in the case that the individual knows that my parents were obese and started diet management or is on a diet to like on a proper diet, make sure that you don't have to like you are not that being is not manifested. Is it going to work that because already you know that your parents were obese in pregnancy and you said that it can be transmitted, like it can be in the gene, the baby can be obese in the future. So in the case that you work on a proper diet management, can it prevent it or you will still have it in the future? Thank you.
To answer that, you when you are genetically disposed, the most important thing that is going to stop you from having obesity is the environment. So the environment there is what you do in terms of exercise, how you live your life. So if you know it is in the family, the most important thing you have to live a healthy lifestyle. That is the most important thing. Yes.
Thank you very much. One from St. Joseph's, please. St. Joseph's. One from St. Joseph's. Absolutely.
That's why she's existing.
St. Joseph's.
Yeah. Like I was trying to say because I was curious. Because you said and the nursing student has already asked you the question because you said if a parent is pregnant and the person has is pregnant and she's obese, the child is likely to be obese. So now it would just be in the form of let's say a selection. So you would wonder that obesity is happening in the country and it's a cause for Allah. But you people are not doing anything. Let's say the medical personnel have not had sensitization or had a plan going on to say that, let's say this is a sensitization on obesity. It looks like you doctors, the doctors are even shy of talking about obesity per se. Because you people are not talking about it. You will tell us don't eat this and you will not tell us what to eat. You will say don't drink this and you will not tell us what to drink. So it means people will still do the same thing. And thank God you said exercise. Most people here are lazy to exercise. You will not exercise, you would say you're nursing, young children. All this is happening and obesity is going on. So it means if a parent is obese, a child will also be obese.
Observation you made, and that's what we are even calling or crying for. I think obesity, we know it's already it's a crisis, in a crisis status in it. But unfortunately, the level at which it should be escalated to is not, like you said. So that's one of the things that we want it to be raised to. Actually, because of the maybe the cultural and the societal issues, nobody really wants to talk about it, like you said. So I think from this discussion, well, we are also part of the NCD, yes, non-communicable diseases. So we'll make sure that it is taken to the level as everybody will be aware of it. Yes, we have any.
Yes. It's still going for me. Madam Magdalene, will you permit me to ask my question? It is a very short one.
In 15 seconds.
Gambia, go ahead.
Okay, I'll start. Regarding you make mention of obesity, and I do go to one community in my area. It belongs to my classes. I do see many men coming to the telling the nurse there that they need the pharmacist rather that they want a medicine that will give them body. So I was thinking that it has some benefits. Now hearing you saying that obesity is it's detrimental to one's health. What are you doing in your ministry to ensure that people are aware that obesity is detrimental to their health?
I think he's already answered that question pertaining to the lady as to what we are doing. So,
how are the effort that they
Yeah, when it comes to medication, it's important. You're right. Even for me, last week, some lady asked me. So that's what we say. Obesity is a systems problem. So why those ladies are doing that is cultural, social, because they think a lady will tell me, "Oh, I need to put on weight because if I put on African, see, it doesn't look okay because the society is telling them that you need to put on weight for you to look good." So these are some of the things that the ministry at the NCD, I think we have to change our message in order to escalate so people know obesity actually is not.
so we have one last question from a member of our IT. So he's going to be limited and ask this question.
Yeah, my question is in connection to what the previous attendees asked with regards to obesity. If you look at the Gambia, I can say 90% all the food that we eat is imported.
Sure.
All your effort at the ministry and all the tackles that you want to put in place in terms of addressing this. How do you go about addressing obesity in relations to the kind of food being imported in the Gambia and also the type of food that we consume?
Like I said, is beyond Ministry of Health. So one of the things that should be done, especially from food safety, they need to have these regulations. When the food is being imported, they need to have how much fat content should have, how much cholesterol. So I was talking to the head of the food safety unit. So one of the things he said, they are actually writing a regulation in terms of the cholesterol content in the food. But one of the things he said is contentious. So I want to believe there's going to be a lot of push against that from the business community. So fighting obesity actually is very tough. It's not easy. And all hands need to be put on deck. It has to go beyond Ministry of Health. So when those regulations are put, you cannot bring in food that has specific amount of, let's say, cholesterol. There will be people who have the money to make sure those foods are not coming in. But like I said, business people who are bringing those ones, they'll make sure that they go to the parliamentarians, so whatever they're going to do so that those regulations will not be passed. So those are some of the challenges.
Yes, so there was a question that from two of the virtual participants, and their questions have to do with vaccine hesitancy. What are we doing to address that? Hmm.
I'm getting interested in this topic, vaccine resistance. It really
cause trouble, especially this pandemic that's just we live in gradually. So a paper was published by Saleh and colleagues. I think he's at this CNS. He, his finding was less than 14% of Gambian population were vaccinated for the COVID vaccine. And then ask why. And the vaccine hesitancy is when there is delay in accepting or refusal of vaccine, despite the availability of vaccine. So and then it's multifaceted and then multifactorial. But there's something that is really known with vaccine hesitancy, which I'm sure our API, the people in the ministry are working very hard to work on. And that's the cultural and disbelief. Some people, and then also, disbelief. And also the media. There are a lot of people come up with a lot of conspiracy theories, with a lot of things that are false, with a lot of things that are not real. So I think the people who are responsible for information should endeavor to bring out the appropriate, the most reliable information, and then the public should be engaged. And then it boils down to what the nurse who spoke here before. That's communication. So, and then, so if you look at it from this perspective, I'm sure vaccine hesitancy is something that we will make a very big progress in this country. Thank you.
So let me say something about obesity before people after this meeting we think that every obese individual is sick, not necessarily. So there is what we call obese but metabolically healthy. Well, even though they say obesity is a disease, not every individual who is obese is actually metabolically sick. So that's important to know. And of course, not because you are slim, lean doesn't mean that you are not metabolically obese. So that needs to be understood. You could be slim, like my size, maybe but metabolically you may be obese. So you may also be obese, but you may be healthy. That is important. So you don't live here and think that, oh, all of these people are sick, not necessarily. That's important.
Thank you very much. I think that brings us. I think it's very interesting and very educating and informative. This is just, I kept emphasizing that the 2-hour seminar is inadequate. That's all the issues that has to do with the whole community healthcare, not even a community healthcare. So this is just giving a bird eye view of the current health sector, where it is, and I think we've taken a deep dive into it through the panelists. We have here, or we still have them here, and it's a dialogue, it's an ongoing dialogue. And they are all stakeholders. I keep saying, when time is racing against us, we cannot feel with Senegal. When time is racing against us, we cannot say, let's look for an inner ticket, visa, to go to Morocco, to go to Turkey. We have to go to what we have. We have to stabilize that road as well. Now, these are just 6 things. They are just so small. It's like putting the drop in a. I'm sure Dr. London, the cardiologist, sitting up there and saying, is the cardiology important? I am sure Dr. Khalil Jan is sitting there and saying, what about mental health? What about Dr. Lee and Dr. Edgar saying, hey, we have to do something with labs, you know? What are they doing today? There's more to talk about. Even ethics in nursing. Medical records, somebody online talk about medical records. It is as important as anything else. If you cannot safeguard, people can find records more than 100 years. Here, we go into records room and start searching. Some people even have several folders because of our inadequate system of keeping records. This should be addressed, I think, and it should be addressed forthwith. There are issues in record keeping. It must come to the front line. And you see, we have to look at the health system in a very holistic way. We cannot do it in a piecemeal way. When we do, we will not get there. It's like a jigsaw puzzle. You have this, you have this, you have this. Where is the piece that should be here? It's incomplete. Okay? Having said that, there have been many gains. Just being able to have our own medical students. 30 years ago, it wasn't there. 20 years ago, it wasn't there. Now we are able to have our undergraduate medical students, and since 2 years ago or so, we've started training. So our own specialists. Dr. Jabi, who's sitting here, is a product of that specialization program. Okay? These things are, it's an ongoing process. And I'm glad that, especially the students who are here today, you are from the outside with hearing a lot of things. I know we've not been able to address a lot of things. That's why we couldn't take many questions, because this is a short time frame that we have. But you see, it's always good to hear 2 sides of a story. Because when you don't, you become biased. When you don't know. Okay, so there is a lot to be said. I would have loved this sort of session to continue with other things. Mental health is a big issue, and I'm very passionate about mental health because we are all affected. Me sitting here might have something that's affecting me. You will not see it. The mad person is the one that is seen out there to say, okay, dafadaf. There is more to mental health, a lot more. There is a lot more. So I think we should develop our mental health system. When I attended this conference in Sierra Leone, West African College of Physicians in 2018, the guest speaker called Professor Omik Bodun was the guest speaker from University College Hospital in Ibadan. She really went into mental health. She just spoke for 45 minutes about how mental health is underestimated. We need to sort of pay attention to mental health. And I can assure you, maybe everybody in this room has issues that is affecting them mentally. So we need to really cater for our mental health sector. Our labs, my background is lab. I'm a virologist, that's my background. You know, we sometimes you send patients to go and do a basic investigation. The patient will come with a result that really is baffling. It flabbergasts you. You know, a patient who clearly has hepatomegaly, very massive liver, you can palpate it right there. You don't even have to do deep palpation. Was sent to go and do imaging studies. The patient went outside because what is at our health system at that time was inadequate. The patient was sent outside. Guess what the patient came with? Gallbladder stones. The patient died 3 weeks later. Massive liver. How could somebody miss such a massive liver? How? So these are the things we have. And then you send a patient for thyroid function tests. I send it all the time because I run thyroid disease clinic. Thyroid, somebody that is clearly toxic comes back with some bizarre results that you get shocked. Where do you complain this to? Where do you go? And you know why? Because we need to emphasize, we need to rehabilitate, we need to have a robust evaluation and monitoring system of all these facilities. Who is monitoring them? Who is monitoring them? Monitoring is not only to say somebody from the ministry is at the hospital. Monitoring is not only to say medical and dental council is monitoring doctors. There is a lot that needs to be monitored. But in my opinion, those who should be monitoring, and there was a question that came, I think, I can't remember who it went to. I added it there. I think it went to somebody. But anyway, it's Dr. Diba. If those that are supposed to be evaluating and monitoring us, they themselves are have an interest, then we are doomed. Who is supposed to be doing the job? Who is so health? The healthcare is multifactorial. Research. You know, there's somebody who also who commented on research. It is so difficult to find papers from the Gambia. When I was writing this thyroid disease paper year before last, I couldn't find anything on the Gambia. Nothing, nil, nada, zero. I was starting from scratch. We need to show more attention, and I'm sure Dr. Bojang will support me on that because he's big time into writing. We need to change the status quo. The paradigm have to shift, you know. But I'm very happy that now we have our own postgraduate school that will be, I hope, encouraging writing, scientific writing. It is important. You cannot have a health sector. You cannot grow a health sector without data. You have to have data. You have to have a data bank. The Gambian need to be able to produce its own scientific document. So I think there's a lot to say, but we'll leave it there. Thank you all for attending. Thank you to the organizers, and particularly to the IT people, and to everybody who is online. We apologize for starting online. We apologize for the hitches in the IT, but we hope we did catch up. It should be ongoing. It's not full stop today. No, it should be ongoing. It's a dialogue, round table. We should continue with it. And we hope some of you girls and boys sitting there, or young girls and young men sitting there, will one day be sitting here, you know, and contribute to national development in the health sector. So with that, thank you very much once again. Goodbye.